Fine. Hello.
Yeah, hello, Andre.
Can you hear me?
Yeah, Mike Bacharach here.
Oh, great. Hello. I can hear you. So,
Good. Yeah.
hello to everybody again.
Thank you. We can hear you well.
Fine. Very good. So sorry for this case. The slides, however, got lost. I just tell you the case as it is. So it's a pretty young man. He's 59 years old. His risk factors is smoking, quite strong smoker. He has been arterial hypertension. And he had a kidney a tumor, a cancer. He got surgery on the right kidney, which has been taken out. That is some years ago. And he has severe claudication, so really only some meters for quite some time actually already, 2.5 years. And we did an ultrasound, and actually also an MR, which unfortunately I cannot see you just now, but we can directly switch to the angio. This is here his lesion. He has a complete occlusion of the distal aorta. At the proximal margin of the picture, you can see on the left side his only remaining kidney, strong lumbar arteries to collateralize down because of that very chronic occlusion. And he reopens right at the origin of the hypogastric arteries on both sides. Yeah, due to the fact that he already had abdominal surgery, we prefer here, let's say strongly, the endovascular approach. We also discuss cases which had not had any abdominal surgery and often, in fact, prefer endo. We think it's a durable solution for these kind of occlusions. We have a 6-French sheath in from the arm, from the left arm. We have 2 7-French sheaths coming from the groin up. We punctured by ultrasound all 3 access areas. And now we want to first try to take the wire down into the aorta. We will be very cautious not to dissect over the origin of the hypogastrics on both sides. Potentially first take, when we approach the hypogastric from proximal, first take some wires from retrograde into the occlusion balloon, maybe there, to open there a gate for the wire to fall down. That's our plan for both sides. Snare the wires in the groins, go up with the wires, and then balloon and take 2 long or several covered stents down, live streams we have planned here to treat that lesion. That's our plan. Fine, so we may right away start. We have all accesses in place and happy to hear your questions or comments. Maybe to do it differently.
So, Andre, Mike Bacharach, so you have a solitary functioning kidney in a patient that has an occlusion that's very close to that renal artery. Obviously risk of both embolization and dissection. Are you taking any specific precautions? What are your thoughts about the potential issue there? You really don't have much room.
If we look back to the picture, I think we have quite some room, correct. If we would see thrombus around the origin of the renals, we would in fact, once we have the wire through, reverse them to work from retrograde, take the wire from the arm to maybe construct that area with some kind of chimney technique. Wollen wir mal den harten gebogenen Teromo lang nehmen? Der steckt als kurzer. Noch ein harter gebogener Teromo lang. Hier ist einer. Fine.
Du hast den kurzen von unten drin.
Yeah, so as I said, I think for a good push, I think it's good to have here maybe a 6-French sheath in from antegrade. And well, ladies, we may just first try with a 5-French long sheath from the arm down. But here, I think with this, I mean, really, I think very benign stump, we may directly take this sheath into the stump. Kannst du den Draht mal halten und den Katheter? Wollt mal hier den Multipurpose runternehmen. And then break in, try to break in here with a with a Terumo stiff wire. I have in fact also here landed or loaded a multi-purpose 6-French guiding catheter into the 6-French sheath, and into that I have loaded a 5-French diagnostic Judkins catheter with more angle. So I can take the angle out, it will be angled, I can pull it in, it will be straight, and altogether I think it's a really robust access here from antegrade to break in. Hast du dort? Okay, so that went smoothly, but here, of course.
Andre, do you ever use dedicated crossing catheters in a situation like this? Like a crosser or front runner or any of those type of devices?
Yeah. No, actually not. We're not using these in this area here so far. I would say it always has been possible to do without, but yeah, potentially in some cases would be of benefit. Would you use this here in this situation?
Well, perhaps if you knew that you were in the iliac, might be something that potentially you could do in the hopes of course, of trying to stay intraluminal. Is it your strategy usually to try to go antegrade, and how do you decide when you're going to go retrograde versus antegrade? From the groins, retrograde from the groins versus just trying to wire from above.
Well, if it's a question for me it's pretty clear. I mean, we see very frequently aorta is dissect proximally, and you really never know where you are re-entering the aorta when you're subintimal from retrograde. So we think the safest way to go through these kind of occlusions is to dissect from both sides into the occlusion and just meet inside, in between. So this is, tut was weh? Tut was weh? Vom Liegen oder wovon? Okay, das ist der lang.
Sie haben noch lang.
So Peter, I think my own experience has been that I've had better luck coming antegrade from above to initially get in. I also have a better sense of where the aortic bifurcation is, rather than coming retrograde. You know, the very few that I've been able to just get through retrograde, and Brian's going to talk a little bit about this, I think, in a talk. And Brian, do you maybe have some comments as well as to what your approach has been? Or I don't want to steal the thunder from your talk, but
no, I don't think you'll steal any thunder here. I'm not going to discuss these techniques so much. I will say that I think I agree with Andre. It's worth trying from above and below. You'd be surprised. You know, sometimes we are surprised at how easy the wire will go retrograde, but as soon as you see it spiraling around the aorta, you know that you really don't want to extend that plane up much further. Sometimes there are techniques inflating or opening up a snare within the distal aorta to aim for, you know, or just continue to do angiography from above to make sure you're staying in line with where you want to be, are some techniques that you can use.
Yeah, we actually do not try to find different. Wo tut's weh? Es tut nochmal weh.
Kannst du mal fragen, wo es weh tut?
Wo tut's weh? Wo? So I feel some poking pain. It's not so nice to hear that, but I think rotating the C-arm around looks pretty okay. I may just take the balloon down to here.
Die Schleuse machst
No, it's okay. And we just predilate that distal area of the common iliac. Jetzt kann es mal ein bisschen drücken, nicht erschrecken. Müssen uns sagen, ob was weh tut, nicht?
Andre, what size balloon is that?
That's only 5 millimeter. Although I think for this kind of ballooning card technique would be helpful to have a balloon which is not undersized. So that was only a very little very few atmospheres. Tut was weh. So now I'll try here to get the wire. Yeah, it's still subintimal. And in fact, maybe we will also take a balloon in from antegrade. What do you think?
Ja, ja, ja.
Ein Admiral, 640 lang bitte. Yeah, so again, as I said, I don't want to dissect here into the origin of the hypergastric. And therefore,
40, ich weiß nicht, wie lang die sind.
we will
Das lang.
take this time to somehow meet here in that area.
640, komm, 640 lang. Also, Jesse,
Yeah. So we will take now a balloon in from undergrad, and not sure what your plans is, if you have presentations to give, or we can work here a little bit,
So we will go
and
to
show
the,
your result.
Andre, we'll watch for a few more minutes, and then we probably will go to the talks, and then we'll come back to you, and you will still be on the monitors in the back of the room so they can watch while we're going through some of the
Ja, hältst du dran?
talks.
Ich weiß nicht, ob der durch den Multipurpose geht. Ja, geht
Ja,
er.
wahrscheinlich nicht.
Okay, naja, doch, glaub schon.
ja? Auch durch den Führungskatheter.
So, invasive Blutdruckmessung. Invasive Blutdruckmessung.
Andre, do you ever consider using a CTO wire from above to try to puncture your balloon, like I've seen you do in the leg?
Hältst du dran? I try to avoid it, but in fact, in some situations, we do use them. But that's actually quite rare, I must say. Here I'm trying now to take a 0.35-inch balloon through a multi-purpose 6-inch guiding catheter. That's a little bit narrow here. No, it's still. That is actually better. Okay, I think I'm through. And I had the impression that right at the distal point of that balloon from retrograde, I didn't have any resistance. I'm pretty convinced that we didn't dissect here across that hypergastric artery. Da ist irgend so ein EKG-Kabel völlig im Weg. Klemme, das nehmen wir den.
Jessica,
So.
ein EKG-Kabel ist mitten.
Just a
im Bild.
moment, wire me. Okay. Yeah, so for snaring the wire, we don't take a snare, but a Judkins 6-inch guiding catheter. Kannst du den Ballon mal rausnehmen? This is maybe a little bit complex sometimes using a Terumo to snare, but maybe actually also easy. Das könnte ich hier mal aufnehmen. Okay, wire, you hold the wire so it doesn't dissect proximally. So I think this is a good place. Da ist immer noch das Kabel direkt im Weg. Könnt ihr das mal wegmachen? Okay. So, let's try to snare it in here. Kannst du den Judkins so bewegen, dass das aufmacht zur Seite? Ja.
Nach innen?
Ja, egal. So. Okay, so this is snaring. Yeah, so we take the wire, of course,
It's
now
always
out
that easy.
from the groin. Not always that easy, no. Ziehst du einfach den Katheter raus. Einfach raus. So, das Klemmen. Dran klemmen. So now we take a catheter from the groin up. Hältst du das mal ganz fest hier? Ganz festhalten. Hier, Sandy. Hier, Sandy. Denn die Klemme. Ich ziehe das hier mal mit ziemlicher
okay.
Gewalt, nicht?
Ja, ich halt.
Okay. So now, we're gonna take a catheter up from the groin. Maybe the balloon, is it too long? Maybe. What do you think? I would take a short balloon or a short multi-purpose catheter to change for a long supercore wire. Yeah, we take a short catheter now upwards here.
Aber du brauchst doch einen langen Supercore, ne?
Ja, aber erstmal den kurzen Katheter hoch.
Andre, can you comment about what degree of anticoagulation you have for these CTO cases where you like to run the ACTs until you cross?
Yeah. So currently we only have 5,000 units heparin. After some time, of course, if it takes too long, we add some more. Preloaded with aspirin. That's actually all. So I think not really something special. I mean, we always, of course, klemmst du den auch nochmal? Care about the brachial access, which, of course, I mean, can be problematic. So therefore, maybe not too much. Und den mal hier klemmen, da klemmen, dann ziehe ich den hoch. Okay. So now we have both wires clamped, and I pull the multipurpose here across that lesion up, and I think we should be across the occlusion. What do you think? Yeah. So now we can pull the wire out.
You pull?
Yeah, and we take a supercore wire in. Nochmal ein langer Terumo hart gebogen.
Leuchten.
Ich habe keine Leuchte. Wo ist die Leuchte? Hier. Okay. Yeah, so this is number one. And yeah, now we do the same for the left side. We will also start again with the arm access and yeah, go down to the left groin. Yeah.
Klar.
Yeah.
Passt schon.
Would you do it differently or? Hier brauchen wir noch einen Judkins Überlang nochmal hier rein.
Any comments from the group? I mean, I think this is a technique that probably all of us have done.
Judkins Überlang?
Maybe not as facile, but
I was going to say,
certainly
not
have
as
done
well,
it,
but otherwise I would do the same.
Yeah, I mean, I think the only thing when I'm a lower, I like below the groin because you can see where you are. If you have perforation, it's easier to manage. So iliac stuff is my least favorite. So if I'm not sure where the wires are, I'll do an IVUS just to see how far apart things are and make sure my wire is still within the confines of the vessel before I balloon. And then the other thing in these cases, sometimes I'll just do one and then send them for a fem-fem bypass. You know, sometimes easier sizing wise and not have to deal with the bifurcation. But yeah, excellent technique.
It's sometimes easy to watch Andre work and do some of these very complex cases because there's no doubt that's what this is, a complex and somewhat high-risk case. What we probably should point out in the back of his mind is a plan for any problems that will arise. And so when I'm doing these type of things, I'll make sure I'll have all my large sheaths in place, aortic cuffs, things like that I would need should I get into some trouble in the aortic region as well. Less so if you're staying in an occluded iliac and not really getting up high in the aorta, but I think that it's always best to be prepared for some type of problem that could arise.
Yeah, I think that's an excellent point. I mean, I tend to use the radiopaque sheaths that Terumo makes so I can see where the end of the sheath is. I tend to get access, just as Andre has done, multiple accesses first. I happen to like that Terumo Advantage wire, which has the glide tip, but is less likely to be pulled out inadvertently once you get it somewhere because it's a regular wire, braided wire. Beyond that short glide tip. So, but I think you're right. You need to have covered stents in your cabinet. You need to be prepared to put a balloon up emergently if you do in fact get a rent or a rupture. And then again, having alternative accesses allows you to do it in a controlled fashion so that you can control bleeding. And as you well know, bleeding occurs really quickly when you rupture a common or an external iliac.
Yeah, I think the 7 French sheaths from below are key too, you know, so you can get the covered stents in.
So I think what we'll do, Andre, you're making this look really quite easy, but I think what we're going to do is, from a time standpoint, what we're going to do is I'm going to have Brian come up and give his talk on technique, and then we can continue to watch as you're doing this. You'll still be on the monitor. So, Brian, why don't you come on up? You're going to be back on. We've been watching with interest as you've stented the distal portion of the aorta and brought stents up from the iliacs. So maybe you can give us a quick rundown in a few minutes of what you've done so far.
Yeah, so we pre-dilated with 620 millimeter balloons. Patient didn't feel anything, so this was, of course, to make space for the stent, but especially also to have a feeling for the diameter, which we could use. Also measuring the length. So we measured something like 130, 140 millimeter lesion lengths. Left hypogastric shows some disease, so potentially may be difficult here to really spare that area from stenting. Right, however, looks nice. And then we ballooned also more distal. And we started here with 60 live streams on both sides. We thought to go a little bit proximal to the beginning of the occlusion because we have the feeling aorta is also small a little bit there. If you squeeze there too much, you may dislodge thrombus, which then hangs into these stents. So we implanted these 8 atmospheres, both sides, no pain. But then, sorry, this enlarged. I don't know how to go back here to regular size. Yeah. So here at that area, now we implanted 2 more live streams, 860, but at 4 or 5 atmospheres, he started to have pain. So therefore, we stopped and we potentially post-dilate this later with shorter 840 balloons. But first, we're going to continue. We still have some centimeters to cover with stents, and potentially we will do this with self-expanding stents. So let's first take a look here to the right hypogastric. There are still some steps to do.
Klemmst du?
So I'm going to ask the panel just quickly. I think I would have approached this a little differently. I probably would have done a VBX, for example, that goes to 16 millimeters. I may have IVUS to see what that terminal aorta was, but I probably would have put a single stent in that aorta. The downside of that is then you have to rewire it. So you have to make certain that you stay above the aortic bifurcation. Any comments as to, I mean, this is where the CRAB technique, in fact, and I think where we need to push industry a little bit to give us better devices that are more easily used to treat this kind of disease. Comments, Peter, Brian, Art?
I would agree wholeheartedly. Now that the VBX has become available, it's actually given us a lot more options than we didn't have before. And that's really one of the nice niches of that device, is that you can take it up to 16 millimeters. And I think IVUS is extremely helpful here, both in terms of sizing and knowing what the underlying aortic pathology is here. So the CRAB technique, I think, would be an ideal treatment in this case.
Andre made a comment that it was worth noting there. He said you can always post-dilate it later, and that I think it's always better to underdilate your stents, see if the patient still has symptoms, rather than getting to 12 millimeters and rupturing their iliac at the first operation. And so VBX, as mentioned, I think that's a great addition to our tools for iliacs, specifically for that reason. You can always come back and conform that to a larger diameter later. All of the balloon expandable stents can be post-dilated a certain percentage over their stated diameter. So that's I think a nice approach, is to put in a device up to the point where the patient feels pain, or you see the plaque moving in a way that you're concerned about a rupture, and then stopping there. If they still have symptoms or still have a drop in their exercise ABIs, there's no reason you can't come back and push that a little bit further.
All right. Thanks very much. Thank you, panel. Andre, we're going to leave you now and go to the cath lab here. We're going to make a transition.
Andre, can you hear us?
Hello, Giancarlo.
Okay.
Yes, we can hear you.
Okay.
Very good to hear your voice.
So.
And with me is Sven Bräunlich again, yeah.
So can you present the next case for us?
Yeah. Can we just quickly only show the last image of our last case? So this was the aortic occlusion.
It's great.
Down.
Yeah.
Yeah. Good results, and happy with this. Yeah. Okay.
Can we see a picture with the flow of the last case or not?
With the flow, yes. Can we go once again there, and can someone maybe play that? Just a moment. Yeah, flow is very good, I think, yeah.
Very nice. Great results. And what is the diameter of the too long part in the aorta of the prosthesis?
8 millimeter. So these are live streams 8. You can postulate them to 10. So we would be happy to have 9 in, but sometimes this was a very small, slim man and small man, and therefore we actually, in this case, happy to have 8 millimeter in. He had quite significant pain when we ballooned the aortic bifurcation with 8, so in this case we would not have been able to safely take 9 in. So, but I think this is okay for him.
Can you just repeat for the audience which type of prosthesis you implanted in the aorta?
So these were live stream covered balloon expandable stents, 2860, 2860, and then we prolonged those down to the hypogastrics just with self-expanding smart stents.
Okay, not covered stent.
Most important is, no, I think most important is to have covered stents in the aorta at the aortic bifurcation, because you find very much thrombus in the aorta, so we don't want to have a protrusion of thrombus through the struts. And I think also a reason to cover the aortic bifurcation with covered stents is that there it's often difficult to open the stents up, very calcified, risk of rupture higher, so it gives you a better feeling to have covered stents there as well. But I think further down into the common iliac, or if it goes down to the groin, the covered stents maybe not so necessary, and we usually take non-covered stents there.
The last question, Andre. The distance between the prosthesis and the right renal artery was relatively short. Do you have a control? That
this is a lumbar artery. So here you cannot see the renal artery. He only has one renal artery on the left side, which is higher outside of the screen. So these two are big lumbar arteries which developed as collaterals over time.
Okay.
Otherwise, if it would have been so close, I would have taken a chimney stents into the renals.
Okay, thank you for this really great case, Andre. So you can go to the next one.